All right. Now we gotta get her screen back up here. Oh. Hi, everybody. We're gonna go ahead and get started. It's my pleasure to introduce Dr. Alice Kim, who is currently the president and CEO of ID Care. I think we all know ID Care, so I'm not going to describe it, but Alice has been president and CEO for about a year, but she's been with ID Care almost 2 years now. Prior to joining ID Care, she had a 26-year career at the Cleveland Clinic as a clinician and senior executive administrative leader. As medical director of enterprise medical operations, she worked in a leadership role and really helped with transitions of care and continuity of care. She also served as clinical operational lead for construction strategy development, etc., for the newest regional hospital of the Cleveland Clinic Health System, opening in 2023. Alice has played a leadership role in IDSA. She continues to play a leadership role for the Cleveland Clinic, serving on their alumni board. She's vice president of membership and president-elect. I did not know that. She also played critical roles in the COVID pandemic response and Mpox health emergency. And I could go on, but I want to give her time to speak. So Alice has been a wonderful colleague. I've really enjoyed getting to know her, and I'm really happy we finally got her here to speak to us. And she's going to talk about high impact healthcare delivery from ID Clinical Practice.
Thank you, Keith, and good afternoon, everybody. Good to see some familiar faces in the audience. So thanks everybody for joining. Again, I'm Alice Kim. I'm again very honored to be here. Before I came here, as Keith mentioned, I had my whole career at the Cleveland Clinic, and the last 7 years of that were not in ID clinical practice. It was very minimal at the time, but again, as he had mentioned, I was in leadership and administration roles in the enterprise operations. So this really set me up for things that I never expected or anticipated that I could do. So today, I just wanted to make sure that we look at what we can do as ID providers, meaning that we are more than we think that we are, and so much is possible, and we can make a difference not only in our patients' lives, but we can make an impact on the greater community healthcare and beyond. So today I wanted to highlight my experiences. I know Keith gave you a quick overview, so you'll hear some of that today. But it's because I want you to understand, again, the power that we have as ID providers, as well as in the power of teams. So I went into ID because I love the complex clinical cases, and really I wanted to be part of the most intelligent team that was the most humble within the hospital community. But it was not until I had my mentors and us sponsors who saw things in me that I never knew or could be aware of that set me on a journey that I've had today. So very thankful for that. And also the team of friends that I've had that also reminded me that I could be a change agent on a greater scale other than my clinical practice. So today I'm going to go through my 4 eras, as I call it, to have you understand how I got to understand the importance of the team and how that influenced me not only on the local level where I was, but how that had impacted the community beyond me, then on the state level, national level, global, and how it evolved into my journey coming here to New Jersey to lead the largest infectious disease private group, physician-led practice in the East Coast. So why do I think ID is so powerful? It's not that I'm doing it. I actually do believe it. I think core to our value is the centered, patient-centric sort of value system that we have. We really want to deliver the best quality patient care, get the best quality outcomes, and we will work tirelessly to get that done. As we know in the health system, we are the thread in the needle between all medical and surgical subspecialties, and also the resources to deliver those high impact outcomes for quality care in those patients. So we are natural sort of the collaborators within an organization and in the community. I think also we love sharing our experiences. It's not only in a venue like this, it's also at different case conferences and presentations, but also the high level consultations that we give. And it's not the consult we do necessarily in the room, but I know when I was at the clinic, it was all those curbside consults that we do on the fly that really form those networks and those relationships that, again, I think are so very, very vital into not only the success of yourself as a professional, but the success of the healthcare community as a whole. So a lot has been published about the values of principles of healthcare teams, and I wanted to shout out this publication that was done by my colleague, Dr. Susan Ream, who was not only my colleague, but my mentor at the Cleveland Clinic. So she wrote this chapter with one of our esteemed cardiothoracic surgeons, Dr. Pedersen, about the importance of the impact of a multidisciplinary team in the management of endocarditis. So as you can see, the values of healthcare teams are honesty, discipline, creativity, humility, and curiosity. That is all very central to us as ID physicians. We don't have to think about that. I think that's innate. And also the principles of team-based care, where we have responsibilities, accountability, mutual trust, effective communication, shared purpose, really patient, developed and guided goals, and using outcomes and to look at measurable processes to, again, ensure that we are doing consistently a high quality job. But not only do this, I mean, the basis and focus of a high functioning team is really the continuity of relationships. So only with that, where you have a shared value system, where you have people supporting each other, can you drive really high impact operational, technological, and even cultural strategies throughout your small organization, or again, on the greater community as a whole. And then the impact itself is going to be, again, what I've mentioned, high quality processes, improve patient outcomes. And also, if you look at it, it's not only the well-being of the patient, but it will help you in the well-being of you yourself in your professional growth and fulfillment. And I hope with this talk, I will be touching on that and how that has impacted me and really is relevant to me today. So as Keith mentioned, I was part of the IDSA's Clinical Affairs Committee, not only as a member, but their last chair. I really loved being on that. And the only reason I say I got on that was because, again, I had somebody in my group who really were advocating for me to be on that. And we were really looking at the value of ID. And so it was for us to recognize as ID professionals who we are, what we do, and how do we make sure that other people recognize that in more of a concrete way. We were trying to see how we can translate that into sort of compensation, but I think that's more than that. So when my colleagues Dan McQuillan and Ann McIntyre wrote this first article on the value we bring to the healthcare system, it was really looking at what we knew we already did on the patient level, meaning our impact for the patients was that we drove the right diagnosis and we also guided appropriate therapy. But then what? What do the healthcare executives, the patients and the people in the regular population know that we do? So this article first in 2017 really highlighted that if we are on a case, at least with Medicare data that they looked at, that we can impact not only 30-day mortality, but readmissions and length of stay. So that's all great. But how are we going to translate to that, translate all that into how we were going to, again, promote ourselves as infectious disease physicians and look at opportunities to do so, especially as we are trying to influence the younger generation to go into ID. So this is a follow-up article that they did, and it was published in November of 2024, looking at how we can, again, promote ourselves with positive messaging. What is so great about ID? If we are doing it, why we went into it, and again, how do we make sure the future generation understands that too? So their main thing was really looking at diversity. And it's not only a diversity of the patient we care for. So we have the whole range, right? We're looking at vulnerable patients. We know how to treat an HIV patient with AIDS, with hepatitis, but also the most complex patients. Again, I'm going to bring up endocarditis, vascular infections, et cetera. But it was also the site of care. We have diversity in the site of care. So we can deliver care in the ambulatory side, the inpatient side, the post-acute side, and also in the public health and industry sectors. So all that really positions us to be critical thought leaders in strategy and all that healthcare has to deliver. So diversity really, to me, and I've lived it and I will see, has brought about flexibility and opportunities for us to be involved in impacts on, I already mentioned the hospital outcomes, but also transitions of care. Again, because we look at a very diverse population and we deliver diverse care at different areas, we can be the ones leading not only transitions of care, but also value-based care. And why is value-based care important? Because we are one of the few specialists who actually care about the social history that we are getting, right? So we're looking at the social determinants of health and how that impacts actually how well a patient recovers and actually gets to the outcome that we want. Because we are in research and education, and we are in public health. We are, again, well positioned to be the leaders in biopreparedness in the pandemic. And again, we all live that. And on the global scale, we've always been the ones to help lead antimicrobial resistance and also cost containment in that front. So again, diversity, opportunities, flexibility, all really help culminate into sort of our well-being and professional growth. So for me, the concept of multidisciplinary teams happened in the early 2000s. This is where at the Cleveland Clinic, we as an ID group sort of went into our little Delta groups. So we were able to sort of split off into the areas that we had most interest in. So there was a neuro group, there was a bone and joint, there was BMT, SOT, et cetera. I was at the premier cardiac center in the world. I loved cardiac device infections and endocarditis. So I was the co-director who founded this subsection. And really, we had a dedicated team of surgeons, cardiologists, ICU, and including them and us was also the nursing and care management team, because again, they are all very vital and important in making sure that the patient's journey is successful. And we set up that we had daily practices that were going to be gold standard and standard of care throughout. So it was a great start to that. And one of your colleagues here actually recently wrote about this on the impact of multidisciplinary teams and endocarditis, again, showing that if you do have a team of teams, the short-term mortality actually is positively impacted. So again, it's not only at the clinic, we've seen this elsewhere and it's been replicated. For me, it was not only looking at mortality, but what can we do with things that are happening around us? So as you can recall, in the 2010s is when sort of the opioid epidemic was going in full speed ahead. So for us at the clinic, we were seeing that these patients were coming in. They represented about a quarter of the patients that we saw as endocarditis service, and the patients were taken to surgery about once a week. So we had that number, but the most alarming thing is, as we started sort of gathering data, was that we knew the clinical presentation, right-sided disease, young patients, the pathogens we knew, and we knew that they were having complicated presentations. But the really big thing that came to us is their relapse rate, and the mortality. So we would do heroic efforts, getting them the right medical therapy, the top surgeons, getting them through their surgeries. But when we left them and let them discharge, they were coming back. So all those efforts were really were almost irrelevant, and we couldn't understand why. So we got another team together, because as we looked at the data, it was because we weren't addressing the primary issue. It wasn't the endocarditis that was the primary issue. The primary issue was their addiction. So unless we combated that together with the most optimal medical and surgical therapy, we were going to go nowhere. So this is the point where, again, we brought another team in. We brought our addiction and psychiatrists and behavioral health experts, and our joint venture partners in post-acute care and community-based rehab, to make sure that we, again, optimize their care management the minute they hit the door at the Cleveland Clinic throughout, and then ensure that they had, again, partners within their journey for recovery. So this was, again, a huge effort by multiple people. The main point of it is the reason that it was so successful is that we had leadership endorsement from the top. So, and that was leadership endorsement not only from us at the clinic, but from all our partners that were going to deliver the same sort of mission for the recovery of these patients moving forward. So we did all these plans, we did the processes, we did the protocols, we helped identify the patients. And the secondary piece of this is, and again, I brought this up in the teams, is sort of the accountability. So we had accountability as a big healthcare system to support these patients while they were there, but also support them as they were leaving. So what were the resources that they need on the post-acute side for them to be successful? And then vice versa, those post-acute were also accountable to make sure they're delivering the same care that we expected in the standard. And the third component was accountability of the patient. So they were contracted. We didn't just say, hey, we're going to send you here and do that. They absolutely knew what they were getting into. They had to sign a contract that they were going to participate in behavioral health therapy. They were going to get medication-assisted therapy in addition to the best medical and surgical care there. So that, I think, was the linchpin, because they knew that they signed this contract and we were going to do and our expectations and responsibilities as much as they were to make sure that recovery was as successful as possible. So on the outpatient side, when we finally got this program developed right before I left, was to make sure that, again, we were all under, again, the same accountability measures on patient measurable outcomes and processes. So we had KPIs set up, so key performance indicators that we all knew about, what we were all striving to. So there was no deviation from what our ultimate goals were. So this was really important because especially when they were not very acute going to the LTAC and we were sending them to community-based program, we had a very different sort of array of patients that we were sending there. So we needed to have some type of outcome measures that we could all look at together to collectively make sure the programs were functioning correctly. So what did we learn? We learned that, again, a multidisciplinary approach and comprehensive one was the most important, and we had to sort of focus on the primary issue at hand, which was their addiction. Care coordination was huge. So again, it was not only care coordination in our institution, but it had to follow that patient throughout their post-acute recovery and then beyond in the community-based programs. Education was key for everybody to understand what the purpose of this program was and why they had to be all in. And as I mentioned, accountability was something that when we contracted those patients, they completely then understood what they needed to do to also make sure that they were participating in the recovery as well. So peer support was one thing that we learned from the patients. They needed a team too, right? It wasn't just us as the medical providers, they needed peer support as their team players to help them get and be successful in their journey. So the cardiology team at the Cleveland Clinic had two big programs called the Mosaic and SOAR programs that started peer support for them in the hospital upon admission and continued throughout their whole journey. So I'm really proud of the work that happened over many years for these patients. I'm going to move on to the Cleveland Clinic Medical Operations. And for those who don't know the Cleveland Clinic, it's a global enterprise. We are not only in the US and Ohio, Florida, and Nevada, but we are in Canada, London, and Abu Dhabi. So really, it's a huge organization, $16 billion in revenue, and really touching the most acute patients' lives all abroad. I was really lucky to be part of this group starting in 2016 and soon becoming one of the 3 medical directors for the enterprise following. So for medical operations, we are the back end people. We are behind the scenes to make sure that we are efficiently and effectively running the hospital. So the clinic has been known for delivering, innovative care models, as well as making sure that we have operational efficiencies. So as you can see, medical operations touches a whole bunch from the time the admissions happens, but everything else that we need to make sure that the patient's journey and everything else to make the business end of a hospital operational. So this is what we do. And then this is what, before I left, they were doing another reorganization of the operations plan, but under my chief of medical operations, we we had 9 sort of divisions. And then we all, as the 3 medical directors, worked alongside each other, ensuring that, again, we were working together in silos. So for my role in medical operations, I was the medical director of inpatient care coordination that looked over the care management team and also throughput and dispositioning, as well as the joint venture LTAC program, and we had that up and had some role in the rehab as well. So unbeknownst to me, I was well positioned for this, but when they asked me to do it, I sincerely did not think I could do it. But when I look back, I know why we could.
That's very good.
Because as an ID person, again, as I told you, we have diversity in the people we touch and the places that we practice. So if we look at just in terms of inpatient stays, septicemia is the top diagnosis out of the top 20 patients come into a hospital system. They account for 8% of the admissions and then 10% of the total cost. So that's one component. Even before admission, if you look at ED admissions, there's 140 million ED visits in the US a year. That's astronomical. About 3% of those admissions actually are related to bacterial, viral, infectious disease, and 13% of those result in admissions. So you can see as ID physicians, ID practitioners, we already have a role of being able to sort of move the needle before they come into the hospital from the ED, during their stay, as well as in the post-acute. So post-acute, as you know, is where they go for further recovery. The good thing in the US, and this hasn't changed, this data hasn't changed for about 10 years, 60%. So the good thing is 60% of patients who are admitted to the hospital usually go home. Hooray. But we do have about 3 to 20% that require further, journey in their recovery, and they go to the post-acute care sites. So those include the less acute is the going home, and then you have the skilled nursing, inpatient rehab, and the most acute patients actually go to long-term acute care hospital. So we were using those post-acute care sites early on to drive length of stay decreases, and we were doing that pretty well before the pandemic hit. And then, as you guys all experienced, the staffing just really exponentially blew that all out of the water. So that has never recovered. So how can we, again, as providers, look at how to improve length of stay? Well, USID providers can also be a change agent in post-acute, because if you see the top 3 diagnoses that represent 7% of the diagnoses are infectious disease related. So there's a lot of opportunity there for us to, again, deliver high quality care, not only on the clinical practice level, but on the leadership level. And I can tell you this is why it was important for us at the clinic, because we had a high volume of very high acuity patients that came there, and we really need to make sure and ensure whatever our main campus providers did, the surgeons and the medical team, heroic efforts were again translated into recovery and successful outcomes. So this was my typical patient on my inpatient floor when I was at the clinic. We get them from a referring hospital, they land in main campus, they get a little better, we send them to LTAC because they're really still acute, they come back. We get them better, send them in, they come back. Get them better, come back. I mean, this would be months worth of trying to disposition the patient correctly. So the main issue was, before I went into the post-acute space, all I knew is when I saw them on consult and I sent them out on OPAT, they were in the black hole. I had no idea where they went. I know the care manager was like, I think we sent them to some alphabet soup thing, but I had no idea. Okay, see them on follow-up, and then they would never come back. So that was really disheartening to me, because I had spent so much time formulating my plan and my management, and then I never got to see what happened to them. So, as I got to be in the leadership position, I had to understand that there were so many different areas that we had to be aware of. There's clinical things in the sort of the blue bubbles that we have to look at, but there's non-clinical factors that we are considered on where those patients go. So for me to transition into post-acute was an opportunity. It was sort of at the juncture where I had my 4th child. I couldn't really go back to being in the inpatient side full-heartedly. And they were like, hey, come over here. I thought it was going to be something horrible, but it actually came out to be something great, because there was not only a leadership opportunity, but there was ID related challenges that I could attack too. So I had already mentioned challenges overall in post-acute were that the patients were highly acute, they're discharging, they're coming back to the hospital. But why? It's because their nursing turnover was, astronomical, as I said, and to have standard competencies that are then translated into patient care, really hard when your workforce is continually turning over. Clinician participation has always been an issue, to even having a provider there to give you guidance was a problem. And then again, we've all experienced this, what happened to the patient there and coming back. So the flow of clinical information, although they have EHRs now, it's the most primitive of primitive, and you really don't get much. So the limitations, of course, are really due to the services and the resources that they are reimbursed to get. So if they are at a high acuity place, moving out, they have more services, but overall they don't. And again, the reputation preceded them, right? We knew that, I hate to say it, that if we sent them, they're black hole and probably mortality. And that's not what I wanted to go into. But again, opportunity for me to make it better. So for the infectious disease related challenges, we knew that, infections are pretty high there. There's a couple reasons why it drives mortality and morbidity and transfers back. It's really because there's a high rate of antibiotic use and misuse. So up to 70% of patients in some type of long-term facility get a course of antibiotics, and then 75% of those patients get them inappropriately given to them, meaning completely wrong diagnosis, completely wrong drug, completely wrong, duration. So that all drives, again, hospital costs as they go back, but in more global situation drives MDROs, and because they're coming back, just disseminates this problem more and more. So I had presented this at one of the ID Fellows conferences on why we should go there as ID physicians. I don't know how well that went, but it really does give you sort of the value props here. If you go, the patients will have access to your awesome subspecialty care. If you go, personally, you have a different advantage, meaning you are completing the whole continuity of care for those patients and actually being the expert in guiding therapy and management. And the hospital systems will love you, as well as the facilities, because you're going to prevent having unavoidable costs incurred, meaning transferring back and then having morbidity and mortality associated. So I took all those things and put this into an implementation of what we did on the post-acute side for the Cleveland Clinic, is get them the service and resources they need. I connected them all to Epic and then got them Cleveland Clinic lab and radiology services. So my Cleveland Clinic colleagues had full awareness of the information flow and the diagnostics that were happening. I'll touch telehealth in a bit. And also we made sure that there was a priority clinical critical care transport. So if they needed to go back, it wasn't that they were swirling around trying to get in. They had a direct access. Clinical support was very, very important too. So the credibility of my main campus physicians to say, I did this great work on this patient, I'm going to let them go, was that we need to have embedded Cleveland Clinic staffing at the sites. So we got the medicine people, I was their ID, we got RIs, the Respiratory Institute, so that's our pulmonary critical care doctors, and then the following LVAD and solid organ transplant teams. This allowed me to then develop clinical programs. I mentioned some of them here. And then really the crux of it all has been the quality and safety measures that, again, they had quality benchmarks here, but our expectations were up here. And they didn't understand that gap, but we made them understand it by working with them, partnering with them, giving the resources. So they trained with us. We showed them the benchmarks if we needed to have, and we had monthly sort of quality meetings with them, each individual. This was 7 different sites to ensure that they were delivering the care that we expected for our patients as we let them go. So the impact of ID leadership as opposed to acute care, you guys all know there's the antibiotic stewardship that can drive down utilization and cost, but also infection prevention. Again, making sure that they are adhering to best practices. Sometimes they don't know what they are, and the guidelines change, and it's really great for them to have somebody to bounce off sort of the new guidelines with them. So when we talk about digital technology or telehealth, everybody thinks that's sort of fairly new, but this has been in the realm for a while. I actually implemented this on the LTAC in 2016 because I knew there was telehealth opportunities there because we didn't have the providers going there. So how are we going to connect them? So again, seeing is believing, right? So they could report back to me that my patient was great, but when you actually saw them in the clinic was something way different. I didn't want that to happen. So again, I knew utilization at that point many years ago was very low in the post-acute. So why not give it to our most acute patients? So I developed this program for our solid organ transplant and LVAD patients. So our main campus teams have peer visualization of their patients as they were getting reports back. So it wasn't always just process and protocol. It was also that they had touch points with their main campus teams. So the patient actually didn't feel left out, that they weren't just thrown to the side, that they were still connected to a partnership program. So that all was, again, a huge focus. I can tell you, we drove down all the hospital performance metrics that were bad to good. We decreased acute hospital transfer rates. And then by the end, before I left, actually some of our performance metrics on the post-acute side were actually better than our main campus. So a lot of great work, and it was a lot of engagement, but it worked. So why did it work? Lessons learned is you have to have committed teams that want to drive quality and make sure that the patient is front and centered. You need to be collaborative in making sure that everybody understands best practices and work with them for them to understand it and guide them. Communication and transparency, key, and communication early when there's something going on. And for me, the big thing was compassion, meaning the main campus providers need to understand the limitations that people have at the post-acute. Resources are not there. So, cut them a break when they're calling to get help or they need to transfer the patient back. And then compassion on the post-acute care team too, to understand why the main campus folks were so hell-bent on making sure their patients, did well. It's because they put and invested so much time into them and they really wanted patients to do well. So all that really formed into a trust situation where you can get credibility, right? So we finally formulate credibility, trust, and actually some reputational lift for the post-acute side because we were all engaged in partnering. I'm going to move on to now COVID, because that is with a team of teams approach exponentially that everybody had to go through. But I wanted to sort of focus on this because I think the state of Ohio did a really good job. So I was the Zone 1 clinical lead and also the deputy commander for Zone 1, but also the incident commander, one of the incident commanders at the Cleveland Clinic. So again, this was really a testament and a test of how well you can mobilize people, formulate a strategy and execute very fast. We didn't have time to sort of do a pilot, see how it did. We had to just run with it. And knowing that we were, again, looked at from the Cleveland Clinic side as the lead for the state, we really had to get going and make sure that we're delivering the highest quality of care. So just to look back, you guys saw the first cases on the East Coast before we did. We were monitoring you guys on the East Coast, and then finally hit us then in March. And again, really impacted everybody, from multiple hundreds of thousands of cases, millions of lives touched, and millions of deaths. So really a testament of how we needed to make sure that we approach this by a really awesome team of teams. So for the state of Ohio, we had these zone approaches, which I'll go into. And these are some of the things, look at load balancing, geospatial mapping and data, what we did for the most vulnerable patients, and then how we attacked through the testing, therapy, and vaccinations once they got a hold. So this is Ohio. This is my homeland. This is where born and raised. Again, I think we successfully deployed and employed things to make sure that the COVID pandemic was attacked in a way that, again, was a comprehensive partnership approach. We have over 188 counties, and we divided them into 3 zones. So each zone was anchored by a major hospital. So Zone 1 was Cleveland Clinic, Zone 2 was Ohio State University, and Zone 3 was Cincinnati. But as you can see, and I'll say, is that Zone 1 had the majority of the hospitals as well as the congregate living situation. So we really had to, again, lift the whole organization on the state level to make sure everything was successful. So when you looked at a high level, this is what it sort of looked like. We have 3 little branches. It's going to be fine. We just had to partner with our facilities and then our public health systems. But as we dug deep, it was this and more iterations of this. Really, there was no way and no an infrastructure already in place that we could just mobilize and get things done. This was all de novo or new, and I'm sure this is what happened in New Jersey as well. So for the one thing that we did immediately was to get communication on board. We had virtual meetings before that was really a thing. So we had a Zone 1 where we had 36 counties, and this is over 200 people on a call almost every day that me or Dr. Wiley, who's my chief of medical operations, was the commander of. And we had hospital leadership. Sorry, I'm gonna take a little sip. Regional healthcare coordinators, which included public health leaders, and then also state level Department of Health, Emergency Management, and the National Guard, all on this call with also state, local, county officials. It was a great way for them to understand that we were, again, all in it together, and that we had certain topics that we were definitely addressing every day to understand what the surges was, what the best practices were, and share those best practices, not only from the CDC, but what we were doing as a health system to support them, and also get sit rep reports. So again, going through each hospital, making sure they knew and we knew what their resource needs were. We also did this on the local level because we were also responsible for the regions within our zone. These are the initiatives I led. So there was 2 buckets, the acute care initiatives and then the congregate living situation initiatives. So again, I couldn't have done this alone. This is multiple team of teams and exponentially engaged levels of calls and meetings that, again, I don't think we're ever going to have, hopefully ever get through before, but really the execution of things and how speedily and how well it was done, I will never forget that. That will be one of the good things I think that came out of COVID. But this was not only for adult, but it was pediatric, just to make sure, again, we were supporting everybody on everything from transfers to equipment and therapy allocation. This is just the sort of how we did that. We had physician level champions in each of the regions that partner with their public health director, as well as their emergency management leadership that would triage, and then it would ultimately escalate to me to ensure that patients were either taken care of correctly on site or transferred to the appropriate level of care. But for me, the most concerning was the congregate living situation. So those weren't just nursing homes, and this included homeless shelters, residential area, treatment centers for addiction, correctional facilities. I think people forgot that they even existed until we had to, be like, hey, we need to support these people too, because they are in the most jeopardy, right? So for me, I put that they were right on this tightrope line, and then really the catchment had to be the hospitals. So as I mentioned, most of the nursing facilities as well as acute care hospitals were in zone 1. So we had a huge responsibility to do that. So the way I did that is I identified all of them. I had it on an Excel spreadsheet. I then matched each and every one of those facilities with a regional hospital lead to be their sister site. So they had direct line to contact, to guidance, to transfer. It wasn't, where do I go? Who do I contact? It was all written out. Communication, again, key, that they didn't have to struggle to find somebody, and standardization. As I mentioned, we looked at that playbook that I will be bringing up. And then how do we coordinate the public health and emergency management level of response? So we standardized all of that, and then ultimately went into centralized data. And once we got that, that was even more impactful. So I briefly mentioned this. This is a playbook that we did for the congregate living situation. So it was me and Dr. Sean Canone, who was at my competitor hospital at that time, University Hospitals, but we came together as competitors and put this out. So again, everybody was reading from the same book. They knew exactly how to keep people on site, and then the transfer as needed, and what the criteria were. It wasn't a who, what, it was all there. So this was really helpful because all the hospitals and all the facilities in zone 1 were in on this and engaged. When I talk about data, this was, I think, crucial, especially in the beginning when we didn't really know what we were doing, but as we gathered more data, we could. So using sort of the EPI data that we got, it guided our workforce planning, and then operational planning, and then also what we were doing on the financial side too. So great coordinated effort again by normal competitors. I can tell you Cleveland Clinic, University Hospital are right down the street from each other, we're competitors. But we all came together to make sure our analytics departments and their data departments were working together to, again, identify patients so we can do action plans quickly. So this is just one of the modeling curves that we did. I don't see the model curves on there, but really looked at how, if you had mitigation efforts, how did that impact hospital census so we could plan for surges. This is one thing that developed sort of early midway, where we can see hotspots in Ohio to, again, see where the most vulnerable patients were, the socioeconomically deprived patients were, and send mobile units to them, and or get our county hospital to send resources to those areas. So the partnerships were not there just solely with sort of state local partners. We had great partnership with our PharmDs within the clinic, and big shout out to them. I love them. We couldn't have done any of the therapeutic launches, which again, the criteria were changing crazy fast. And we also got our ethics team involved to make sure that we were, again, ensuring that the most vulnerable and high-risk patients were getting the very low allocation of supplies and therapeutics that we had early on. So they were instrumental in making sure that the providers knew what they were doing, just based on the EHR. Best practice alerts were very helpful, had them know how to order them and then get easy access for the patients to get them. So we had home delivery of the therapeutics when we got them. And then we won a big award for the clinic as the caregiver team of the year that year. So a great effort, again, couldn't have been done without partners in crime. This for me was just a stepping stone of what I did as co-director. This is Dr. Canone, who I've been talking about, who helped me develop the playbook. Is we were asked by the state of Ohio to be the medical directors of our first mass vaccination site. So this was, again, with now federal partners at FEMA, Department of Defense, Ohio National Guard, 650 members helped us convert this college, it's on Cleveland State University auditorium into a mass vaccination site. And we vaccinated over 130,000 Ohioans in a span of 12-week mission. And what I learned from that is servicemen and women, God bless them. They are respectful. They are committed to their work. They're compassionate. And it was just a joy to see them in action and work with them. This also then led to the deployment of a Department of Defense at the Cleveland Clinic. I spearheaded this Air Force medical response team. This is sort of at the tail end of COVID, but for us as a quaternary center, sort of in the Midwest, we were still getting all the really high acuity ECMO patients that required still more care delivered to us, and we were still having staffing shortages. So even them coming for a few weeks really was, again, a joy to see how everybody from many different sectors came together to make a successful outcomes for our patients. So what did we learn from the COVID pandemic? Basically, the big healthcare systems really have to be in and helping and making sure that everybody else wasn't getting overwhelmed. But that isn't all on us. It's a partnership and collaborative approach on how we were going to coordinate this, not only standard practices, but also how we were going to take care of the most vulnerable patients with healthcare equity and most acute patients on making sure that they were, again, getting to the places that we needed to be. The trials and the disinformation, I think we are still seeing the impact of that. I think we need to work on that. And then again, the lingering effects of the workforce and burnout, I think we, again, understand that that was probably one of the instigators and still an issue we have to discuss and continue to discuss. So this was just published. I was one of the authors on this, and this was a collaborative partnership effort with CDC to ensure that we don't forget what we did. So on that last slide, I said the one thing that we need to do is make sure we don't forget what we did and pass on the knowledge that for the next thing that's going to happen, because it's going to happen. So it did happen, right? The Mpox came shortly thereafter. And I can tell you when I did the zone 1 calls again, most of the public health, the emergency management teams, they were all gone. Nobody understood what the care coordination was, and they had all maybe probably burned out and left. So really important, we thought, for with the CDC and IDSA to ensure that we have sort of a playbook and something to launch off on as we look at the next generation of workforce coming through. So the key is that ID physicians, we play a crucial role in this. This is sort of our bread and butter, right? And those are all the values that I had mentioned before. And all the things that we need to look at strategy on how to make sure that we don't get into jeopardy situation before. It's everything that I mentioned: collaboration, standardizing, data, how do we communicate, early dissemination of whatever information updates we have. And again, training ID physicians not only to be clinicians, because you guys are the clinicians, but how do you do higher level sort of leadership roles? Incident command, I mean, that was something I was thrown into, but gosh darn it, thank God, because it makes you learn how to mobilize and strategize very quickly and execute. And media training. So that disinformation that was, again, happening in the beginning, how do we make and ensure that those leaders that we are appointing to or grooming are able to message that clearly to the public? Because it's a different audience. So how do we do that? So this, again, just published, and my portion of it was really looking at the health system level on the contribution of COVID response. I'm going to sort of end with this as a place where I was looking for how do we work with people within but without, on sort of building from nothing. So in the midst of COVID, I was asked to be the operational lead of the newest hospital build for the clinic. And it wasn't just going to be a regular hospital. It was supposed to be the innovative hospital of the future. And the reason was it was supposed to be lean. So lean efficiency, lean operations. And so for me, it was a lean, mean healthcare machine. How do we do it? Because it was going to be something different model of care, meaning small build. Access was limited, but it was not to limit access to our subspecialists. So I brought telehealth into all the patient rooms and all the outpatient rooms. So that was not an issue, but it's really a model of how we effectively mobilize patients, not into one hospital, but how do we use multiple hospitals to take care of our patients and launch them in a coordinated effort. So it was great because I got to work not only at the team of teams within the clinic, from non-clinical to clinical to shared, but also then brought in our construction or strategy first, then our construction people, engineers, designs. I mean, I had a ball with that, but who knew I could do that? I did it, but being thrown in it was a joy because again, using up and building on all those skills and experiences I had. So this is what we started out with. This is what we ultimately ended up with. This is our, the lobby and then all the telehealth rooms and then the ORs. And then we had opening day, July 11th in 2023. And has been one of the most successful hospitals with the highest sort of nursing scores and quality scores. So super proud of that. But that launched me into where I am today. So all that experience evolved into coming to New Jersey. So I said from the Buckeye State, I don't know if you guys knew that that's what Ohio is, to the Garden State. I didn't know what the Garden State was, but now I do. So why? I mean, this was a huge leap of faith, but again, it was not me looking out for this. Was a friend, a relationship that I had built over many years from IDSA, who had known my experience and connected me to Ron Nahas, who's the founder, who was looking to have some succession planning. So for them, it was to rebuild. For me, it was to refocus. What else could I do? What other skills can I build outside of the Cleveland Clinic? So for those that don't know us, I think you guys all do know us. ID Care is really a big organization. It's the second largest, I think, ID group practice in the country, but the biggest on the East Coast, and really expansive, right? We're in multiple hospitals, multiple post-acute sites. So really the comprehensive, I said, diverse location approach is here, and other service lines that, again, make us a very comprehensive organization is that we do have a robust clinical research division. We do telehealth, travel medicine, wound, infusion, legal review, et cetera. So sort of all the gamut of what an ID physician can do and should be doing for opportunities and diversity. So these are our ambulatory care service locations. We have 10 offices to support all the different hospitals that we are in. We are in all the 3 to 4 major hospital systems, and we are in 7 of the RWJBH hospitals. So thank you guys for your partnership, working with our team. The ID Care physicians, APPs, and providers really do love working with you guys and help support your patient care directives and initiatives. So for us as an organization, they hired me to drive their business line. So I told Keith, I just started clinical work, but really they didn't hire me for that. So some of the business aspects that I know some people were asking, or, what are you trying to drive? And I will get to that slide in a little bit. But just to show how robust and how well they've sort of worked and developed and built this practice is that we see over 380,000 patients a year. Our sites of care, same with you guys. I think it reflects the inpatient side as most of where we see, derive patient care, but we also have outpatient and post-acute, like I mentioned. Our revenue sources are mostly clinical, so that is what we do best. I understand, but there's also other opportunities, again, because we can do it in leadership roles, administrative roles, and other things like that. That again, this group has been really good at driving home. And then looking at the business side, we always have to look at our payer status. And again, we do the best when we're looking at vulnerable patients. The main drivers of our revenue are Medicare and Medicaid. And we're proud of that. We want to make sure that we are doing comprehensive care, not only for the complexity of the patients, but also for the socioeconomic classes that we have responsibility for. So when I came, again, it's been exactly a year since I've been here, was really looking at a new vision and strategy for ID Care, organizationalized, really looking at a different way of governance and management and financial structure was where I was coming from, because I had a different view, right? I had a different perspective coming from a hospital system, now going into private practice. So we've been working on that for the last year or so, and also making sure that they have organizational sort of metrics that they are looking at together. So OKRs, what are the objectives and key results that we as an organization want to look at, not only on as a whole, but on the financial outlook, workforce, innovation, and technology and research, because we hit all those. I almost say that ID Care is like a mini hospital to me, because we actually do look at all those. And how do we engage our providers? So I did a new committee structure where we're not only engaging the physicians, we have the young physicians, so our associates, our APPs, because they represent half of our workforce, in committees that are going to drive some of these initiatives that they want to drive for the organization. So that has all been frameworked out. We're working on the OKRs now because the committees were just formulated, but again, a lot of great engagement that I'm seeing within the group. The budget and the finances, we were looking at it, we just proposed or just actually implemented a new format. We're working at service line P&Ls. This was never done before, but again, it lets us nimbly look at the budget and where we are and how we are, need to sort of move and pivot into different areas, and directions based on, finances as they come, straight ahead. Performance management, this is accountability. Again, we need to have people that are in management positions that can drive that. So we have a chief structure with a medical officer, a nursing officer, and an operating officer, as well as those in the management team to help drive everything with the strategy from the ground up. So they have reports. I wanted to highlight some of the initiatives. These are not a lot, but the ones that I've highlighted are really, again, highlighting the partnerships that I brought in from outside. So again, I've not forgotten about my networks and my relationships outside. So I have paid friends and from consultant groups that were IDSA staff that are helping with coding and billing. I have my nursing team at ID Care go to the nursing team at the Cleveland Clinic to understand nursing ambulatory management. I have our Cleveland Clinic emergency management director come here and formalize an incident sort of management team as well as environment care rounds, because we're big enough to do that. And we need to put, again, patient and employee safety at forefront. And also now we're going coaching mentoring program for professional development, not only for our providers, but for every level of employee. So I'm bringing in Susan Ring, who I mentioned on the first couple slides, who is now in retirement, but also a coach and mentoring credentialed professional. So she's going to help us with that. Again, I wanted to drive home partnerships because we cannot, and I cannot do this alone in a private practice. So Keith, again, I'm grateful I got to meet Keith again from a relationship. So he knew one of my former fellows at the Cleveland Clinic, and that's how we got connected. But it's been great because, for me, we have to work together to be successful. It's not alone, it's with the team. So for me, I've been really trying to drive home sort of how we work together with the hospital systems on not only agreements on sort of directorship levels, but how do we do value-based programs because we know how to do it. And infectious disease programs are something important because I don't want to just be that consultant, that private group consultant that comes in. I want to work with the hospital in driving performance metrics because we can do it. I showed you that we can do that if we are part of that sort of team and developing that and making sure we are on the same page with driving performance. Keith and I have been floating around this combined academic and private practice fellowship training, again, because I think we have to set up our young colleagues up for success so that they know, again, what opportunities are there. If they don't know what it's like to work in this setting versus that setting, how do they make an informed decision on what they want to do for a career path? And just recently, we just did a partnership with Rutgers where we do have a combined PharmD, ID PharmD that's going to be coming to us in September. That will have Rutgers academic appointment and then work with us at ID Care for clinical private practice. So this is the building experience that we just had at ID Care. Just opened 2 new offices in the last few weeks. So I'm just going to close with this. The top 10 list. I don't know if you guys know the top 10 list. Who is it? Keith? David Letterman. So for the young people, late night show used to be David Letterman. So he used to do this top 10 thing, which I think this gentleman, Dr. Cottrell, did really well, because the question we all say, and this is what I sort of brought up, what is our value? How can people recognize and give us attribution to what we do? Because we don't get comped very well. We know that, but we didn't go into that for the comp, right? We do have a lot of career satisfaction, as I've been trying to say. There's so much diversity and opportunity that we are expert at doing. We just have to tap into that. So he did this top 10 reasons, which I think was really cute and really drove home to me and really was sort of a closer for my talk. Why do we go into ID? Well, again, as I mentioned, I went into ID because I love being that detective. We network. We're great at that. Social butterfly, social history. I swear we're the only people who care. And look at that. You help people, the most vulnerable patients. Dang it, we do that well as ID physicians. You can still do your internal medicine because you have chronic patients, so you're not giving that up. Opportunities abound. So the world is your oyster, and I am a testament to that. I didn't know I was a testament to that until I was asked to do a talk, and I didn't know what to talk about. But yes, you can do it, but you can't do it alone, right? So You'll never be bored because, again, I'm saying opportunity is there. You just have to find it and get to the right team and have people endorse and support you. Cool toys. This is for sort of the diagnostic molecular stuff. You will be well positioned, and that's not only to lead value-based care. I'm telling you, it's to lead anything in the hospital system that you can have impact on. And you join a group of providers, colleagues that you know love what they do. And I love that. I still love that. So I thought he did a great thing with this. Not as funny. I don't deliver as well as he does, but I thought that really tied everything together. But for my key takeaways is that the power of ID is really, to me, the 4 C's. The core is that we value and we care, or our core is that we care. We value the patient, but I want you guys to also care and value yourselves. Like, we are so much more than you think you are. And again, I had sponsors who saw that in me. Thank God. I'm so grateful for them. But I want you to sort of open up and be, to see that in yourselves. There are challenges and change, and that's normal. But this again opens up diverse opportunities for you to do anything and see if you can do it. And of course, builds resilience. Relationships, collaboration is exactly and the most important thing, I think, to get anything successfully done, not only for yourself and your well-being and professional growth, but again, to make an impact on a better, broader, and bigger stage. And again, I think we all are committed to quality and integrity. And that, again, is for me the crux of being an ID physician, and so proud that we all are committed to that. So I'm going to end with that. I think over 2 minutes, and I'm sorry for that, but really thank you for your time and for your attention today.
Thanks, Angel. Excellent talk. I know we're a little bit over, we started a little late. So I guess we have time for a question too. Any questions from the audience?
Yes.
Oh, we got 2 here.
So in the first part of your talk, where you talked about putting together your groups at Cleveland Clinic. One of the things that we always had problems with historically was getting buy-in, getting support from hospital administration. So how did you talk them into that, or are people more enlightened in Cleveland than they are in New Jersey?
That's right. No, I think we all struggle with that, right? And for me, it doesn't even have to be the high level. It's even the people on the ground. It's the why. Why are you asking that? We always say, why is that? But as I mentioned, the endorsement and that you need to get from the leadership is huge. So for me, I had my endorsement after I had built up my credibility to say that I'm doing this. Okay, Alice, you're good. The chief of medical operations endorsed everything that I did, and without question. So that, I think, for me was a linchpin, but I had worked on that credibility factor for a while. Constant engagement and not giving up, especially we had institute chairs there, again, pushing the heels back, digging their heels in. But if you constantly, in not a threatening way, in a collegial way, keep on engaging them and making sure they understand the why of it, and then get the people that can talk some reason was it. So I think for me, it was endorsement and leadership for above. They need to be engaged and understand it, and also the why. Because if they don't understand, they're never going to never endorse anything that you're going to do. So, and I think at the clinic too, it might be just the culture too. You're right. There's a big component of that they want us to be innovative. They want us to sort of give out and pilot things. We usually don't have any pushback, and fortunately there they have vast resources too. So I don't put that down, because we did. I had admins galore. I had data analytics galore. I just had to ask. So that for itself, I think made it easier to get these teams together and work very quickly.
Yes, thanks for a great and inspiring thought. I'm just wondering, as your career is thinking changed and evolved as far as your responsibilities, you need a different skill set. What would you know versus clinical care? You kind of have to know a lot how to get out there, but how much of building that skill set you feel like you got through formal coursework classes versus just figuring it out along the way?
Yeah, I get that question a lot, John, because I got my MBA. I graduated the same year my daughter did from high school. So we both graduated in 2021. And again, through the pandemic, I was doing my EMBA. It was painful, right? And my professors didn't believe that I couldn't turn in that essay, 10-page essay, because I was actually on a panel discussion for the state. So I can tell you that most of the MBA program, I loved it. I wanted to go to the program to learn about finances. So did I learn about finance and accounting? Yes. Everything else about how do you build a team, how do you work with people, it was all about relationships and networking that we already knew. John, I'm gonna tell you that from my heart. Like I was like, I already did that because that's what we do in clinical practice. So I would say it was good for me to understand the finances. And then the other great thing about the MBA was looking at and learning from your classmates that are in different sectors, not in healthcare, different sectors of business. So I had a guy, my good friend in banking, I had an aerospace engineer. I had somebody who was in a family business. Just learning from them, I think was golden. So the coursework itself, okay, good. Yeah, get the legal and that, but I can tell you, you inherently as an ID doctor know how to do the relationships, and it's relationships and networking that are key to anything.
I'll just wrap up with two quickies. First one, just to follow up with what John's saying. So never any formal leadership training.
No,
Me. The very fast. You presented the data on the endocarditis multidisciplinary group, which when John and I were in Michigan, similar at Duke, we had something loose but similar. I think important thing which Mel was referencing is you need resources. So, and resources they aren't just gonna give you. So that make one thing that you talked about bringing in the addiction experts when you noticed that your numbers weren't so great. Do you have any data subsequent to that? Because you showed the data for like 9 recurrent cases out of 20 and deaths and opioid relapse. Was there any follow-up data showing that bringing in the addiction folks or making it even more multidisciplinary?
I did, and I lost the file, so I couldn't do that. I couldn't update you guys because that was as I was leaving that we were finally getting the programs up and going. And I think we probably they now have years worth, but when I left, I had a few months worth, and I didn't have it in my file. But I will report back. I will get that from my colleagues.
Publishing?
Yes. Yes, so like I said, that's one thing I do miss. Like I started a bunch of programs that I didn't get to see into sort of maturation, right? They were in their infancy, toddler stage, and you really need like 5 to 7 years for a mature program to show sort of outcome data that would be relevant and impactful. I'll get back to that.
Yeah, well, so on that enterprise model, the multiple system, Keith said, we did that in Michigan, and the hardest part I found was logistically to get in the room with the surgeons, right? Because even before you agree that we had an issue with injection drug use and relapse, and that was important, but just the decision of when to operate or not is such a challenging decision that requires ID, surgery, cardiology, neurology often. And the only reason it seemed to work in Michigan is because there was a senior surgeon who stopped operating, but he had trained the rest of them. So he had the buy-in of everyone, and he had the open schedule to be there at 4 o'clock every Tuesday afternoon. And that's the only way that we, through him, built relationships with the surgeons, and they learned to trust us, and then we could have that back and forth. But I was just wondering what your model was like at Cleveland Clinic, where you may not have that similar.
No, so this is where I went back with that physician champion. So that was one thing that I still at my foot on. You need a physician champion to actually spearhead initiatives, right? So we did that at endocarditis too. So we had 2 surgeons that were our endorsers and supporters, were always there at the meetings. And then again, for any of the cases, we did have case conferences on specific ones, but they knew they could curbside us on any time, but you need those champions within each of those groups. And again, those champions, again, held true for all the other things, all these other huge initiatives that we needed to do partnership. You just need those people to talk on your level and understand what you're trying to drive at, and that already have the respect and credibility within their team to do so, right? So I think that definitely helpful and needed, essential.
I think there was a Michigan also, Shui was implementing multidisciplinary with his Ulster team, but the plastics people would never come. And so it was, they were the people that you needed. I mean, we couldn't, if all the decisions were made, we still had to go buy something. So,
Right, you just need that one, but it's true.
well, thank you so
No,
much.
thank you for your time.
Thank you.
Nice meeting you all.